Hello everyone, I'm Valerie and I'm going to speak for a few minutes on OptiBirth and the early phases of the project where we developed the intervention. So the overall aim of OptiBirth was to improve maternal health service delivery and optimise childbirth by increasing vaginal birth after caesarean section through enhanced women-centred maternity care across Europe. The project involved 11 partners from 8 countries across Europe, and the project was funded under the EU FP7 framework programme. The project was divided into 7 work packages, as illustrated here, and each work package had a work package lead to oversee that work package, supported by a team of researchers of various sizes. Focusing on work package 2, a series of evidence synthesis and evidence generating activities took place. So these involved the conduct of 3 systematic reviews, focusing on evidence from clinician and women-centred interventions for increasing VBAC and a meta-synthesis of women's experiences of VBAC. In doing these systematic reviews, we only took information from interventions that were shown to be effective to inform the OptiBirth intervention. We also undertook 4 qualitative studies with clinicians, midwives and obstetricians, and women in countries with both high and low VBAC rates. And evidence from these qualitative studies also informed the OptiBirth intervention. Based on the evidence generated from these activities, we developed a complex intervention which consisted of the provision of evidence-based education for women and clinicians, access to online educational resources, introduction of communities of practice where women and clinicians came together to share knowledge, and these communities of practice were implemented at the end of the antenatal classes. We also appointed a midwife and obstetrician opinion lead in each intervention site, and there was audit and peer review of caesarean section rates and a joint discussion on these by women and clinicians. In each intervention site, the intervention was delivered by the midwife and obstetric opinion leads, supported by their team of researchers. A series of key activities were fundamental in helping to progress the development of the intervention and also implementation of the trial itself. Some of these included a project kickoff meeting that was held over 3 days, and also ongoing communication throughout the development phase was critical. So I'm going to hand over to my colleague, Professor Deirdre Daly now, who will speak more about some of these activities.
Thank you very much, Valerie. I'm going to focus on the cluster randomized trial and how it progressed and how we monitored what was happening. So initially, the sample size required for the study was estimated at 1,680 women in 12 sites. And that would enable us to detect an absolute increase in the control group to 40% or to 40% in the intervention group. Ethical approval was gained in all sites in advance and granted by the university. There was 6 sites in Germany initially, and 1 of them didn't take part, and then 5 sites in each of Ireland and Italy. Sites had on average 1,800 to 8,500 births a year, and they all had VBAC rates less than 35%. Sites of similar size were matched and then randomized 1-to-1 or 1-to-2, favoring the OptiBirth intervention. And details of what we did are published in the protocol. Recruitment to the pilot study began in January-February in 2014, and the main trial started in April-May 2014. In order to be eligible to take part, women were aged 18 years and over, had 1 previous lower uterine caesarean section, had a singleton pregnancy, spoke the language of the country they were giving birth in, gave consent. We recruited a total of 2,002 women, 1,195 to the intervention, and data were available for almost 2,000 of these women. We also collected data, self-reported data on antenatal and postnatal health and healthcare resource use and expenditure. I want to pull out a few key points from the monitoring of the trial. So the trial group met monthly, and these activities, those meetings were really useful in monitoring how recruitment was going in each site, how the classes were going, and the MOLs and the OOLs, so the obstetric opinion leads, had a step-by-step guide to manage the process and so that we could also assess fidelity to the intervention. Those monthly meetings were really important, especially when challenges arose. And to monitor the recruitment, this is what we did. This is the template we used. Monthly meetings were held to monitor recruitment monthly, but also then to monitor cumulative data to show that we were on track throughout the trial. All of the monitoring activities went really well, particularly the monthly meetings and the additional meetings with the postdoctoral researchers in each site. The one aspect that was challenging to monitor, and that was simply because of staff rotations, was the total number of clinicians, midwives and obstetricians and other doctors who attended the sessions. I'm now going to hand over to Cecily to tell you all about the results.
Thank you, Deirdre. So the trial results from the cluster randomized trial, there was no statistically significant difference in the change in the proportion of women having a VBAC between 2012, the year before the study started, and 2015, the last year of the trial. In the intervention sites, the VBAC rate rose by about 1%, but it also rose about 1% in the control sites. However, in Italy, one of the 3 countries that was involved, the VBAC rate in the intervention sites had been very low, 8% in 2012, and it rose to 22% in 2015. So that was a significant difference. So the Optibirth intervention may assist in supporting VBAC in sites with very low VBAC rates. The maternal and neonatal outcomes, perinatal deaths after 24 weeks gestation were the same in both groups, 0.34% compared to 0.51%. There was no difference in the rates of admission to neonatal ICU, 7.7% versus 8.1%. And there were 2 uterine ruptures, 1 in each group. Both women and babies were discharged home well on day 4 and day 5. And that gives a rate of uterine rupture of 1 per 1,000 women, which is much, much lower rate than you see in any of the older literature, where they quote rates of things like 1 in 200. So the true rate is probably nearer that, 1 per 1,000. The quality of life results, you've got 3 graphs there going from left to right, Germany, Ireland and Italy. And in each graph, going from left to right, it's going from antenatal to postnatal. And as you can see, women's quality of life increases from the antenatal to the postnatal period because they're much less anxious now they've had the baby and they're much happier. But you can also see, if you look at the blue lines that are the control group and the green lines that are the intervention group, the women in the intervention group, without fail across all sites, had a higher quality of life than the women in the control group. And we feel that's a very important result, that women actually benefited from going through the Optibirth intervention. There was an anthropological study carried out in one site in Ireland, and this showed that while the overall culture in the field site did not change, smaller, more individual cultural changes were observed from both women and clinicians taking part. The absence of participation by senior consultants was found to hinder implementation of the intervention. And it was women who were driving change around mode of birth after caesarean section, rather than the clinicians who did not engage fully with the intervention. One recommendation that came out of this anthropological study was that we needed midwifery opinion leads in the labour ward as well as the antenatal period to support the midwives and obstetricians there. So in summary, our results showed similar and low adverse maternal or neonatal outcomes between women exposed to the Optibirth intervention and those who were not, and higher quality of life scores. The intervention thus appears feasible and safe. The country-specific results appear to show that the Optibirth intervention may assist in supporting VBAC in sites with very low VBAC rates, but more time is needed for change to take place due to cultural issues. And one anecdotal piece of evidence that came out from the anthropological study from the one site in Ireland showed that the obstetric opinion lead there was able to increase his personal VBAC rate from 35% before the study started to over 65% at the end of the study. And he was delighted with this. His whole motivation and belief about VBAC changed during the period of the study. However, all his colleagues decreased their VBAC rates, so that overall he was very disappointed at the end when the results came out, and it showed that there had been no change in VBAC rates in the hospital as a whole. So you can see very clearly how individuals can change, and any individuals who find it very difficult, they need further support to try and help them to improve their VBAC rates. Our conclusion is that future research is needed to refine the best way of promoting VBAC. But we believe very strongly that implementation research or action research may prove the most beneficial rather than conducting more randomized trials. And that's because of all these cultural issues that were involved. Because it was a randomized trial, we couldn't modify the intervention in any way for any one of the 16 sites. And that was a problem because in different countries and in different sites, the clinicians wanted to make small changes and we couldn't let them. Whereas with implementation research, they could make those small changes. Anything that worked would be encouraged and supported. And also you could see the results as they went along, which we were blinded to, obviously, as is correct for a randomized trial. But if you knew that no change was taking place, you could provide more support in that particular area. So we think implementation research is the way to go. This is just a happy outcome to show you. This lady was not in the trial, but she's an Irish woman who had to travel to the UK to get what she wanted after a previous cesarean section, which was a home water birth. And you can see that this was a transformative experience for her and for her partner. And I leave you with a thank you to the women who took part in this and all the staff in the study sites, particularly the opinion leads and the researchers and postdoc researchers in each country. And this is a snapshot of most of the Optibirth team. Thank you for your attention.
Thank you. Bye-bye.